Assalamualaikum. My seminar today is about the salivary gland disease. First of all, we're gonna talk some introduction about the salivary gland and then salivary gland aplasia, mucocele, ranula, sialolithiasis, necrotizing sialometaplasia, and allergic sialodentitis. Salivary glands are tubular-acinar exocrine organ that responsible for production and secretion of saliva, which contain a various organic and inorganic substances which help in mastication, deglutition, and digestion of food. We have major and minor salivary glands. The major salivary glands are parotid, which is open into the mouth by a single duct, which is the Stenson duct, and we have the submandible salivary gland, which is open also into a single duct, which is the Wharton duct, and we have the sublingual salivary gland, which is opened by duct of Ravenous. The major salivary gland, which is distributed into the mouth into different parts into the mouth by the lingual, the labial, the buccal, the lingual, the palatal, alveolar mucosa, and the floor of the mouth. First, the salivary gland aplasia, which is a rare developmental anomalies that can affect one or more of the major salivary glands. The clinical feature, it has been reported more frequently in men than women by a ratio from 2 to 1. The most significant symptoms are the xerostomia, the leathery tongue, and its high risk of dental caries and erosion. Like in this picture, we see the salivary gland aplasia, we see the leathery tongue, and the high risk of caries and erosion. The treatment, we give him sialogout medications such as pilocarpine and the semivilline to increase the salivary production, and sugarless gum to increase to stimulate the salivary flow. The mucocele, it is a swelling that caused by accumulation of saliva at the site of the traumatized or obstructed minor salivary duct. It can be classified histologically into extravasation type and the retention type. The extravasation type, which is the most common type, and it results from trauma to the minor salivary gland excretory duct, which cause laceration to the duct, result in pooling in the saliva in the adjacent submucosal tissue, which causes swelling. The retention type, it is caused by obstruction of the minor salivary gland duct and often by sialolith or tumor. The block of the saliva flow, it results in accumulation of the saliva and dilation of the duct. The clinical presentation of mucocele, it's painless and a smooth surface swelling. The superficial lesion, it's frequently characterized by blue in color, like in this picture, and the deep lesion, it's more diffuse and has covered by a normal mucosa, which has no blue color. The differential diagnosis is the salivary gland neoplasm and soft tissue neoplasm, vascular malformation, and vasculobullous disease. The treatment of mucocele, it just remove the entire lesion with the feeder salivary gland and duct. It will happen recurrent in mucocele في حالة incomplete remove of the lesion. Ranula, it is a mucocele that occur in the floor of the mouth, range from the sublingual gland. It's much bigger than the mucocele. The cause of the ranula, it's a mechanical trauma to its duct of Ravenous, resulting in extravasation of the saliva, or obstructed salivary duct or ductal aneurysm. It is blue, dome-shaped, painless swelling in the floor of the mouth. The treatment of the ranula, we just remove the entire lesion by marsupialization. Like in this picture, we show the operation of the marsupialization. Sialolithiasis is a calcified organic mass that form within the secretory system of the major salivary gland. The etiology has three groups. First, factor favoring saliva retention, like irregularities in the duct, local inflammation or dehydration, or by some medication like anticholinergic and diuretics. Second, saliva composition like calcium saturation. Third, the bacterial infection. The clinical feature is it is most common in the submandibular gland from 18 to 90 from 80 to 90%. It happens in the submandibular gland because first the tortuous course of the Wharton duct, second the high calcium and the phosphate level of the secretion contained, and third thicker mucoid secretion of this gland. It may be responsible for a greater tendency to form salivary calculi. The patient with the Cialon most common has a history of acute chalky pain and intermediate swelling that affected the major salivary gland during the meal. Like in this picture, we see the Cialon in the submandibular gland and to the Wharton duct, and here the X-ray to the submandibular calculi. The treatment during the acute phase of the Cialon therapy is a primary suppurative. The standard treatment during this phase is involve analgesia and hydration and antibiotic. The use of cialogac like simivilin and pilocarpine or the chewing gum. Massage to the gland and heat applied to the affected area. It may be also benefit. The stone at the near the orifice, we just do milking to the gland. Necrotizing cyalometaplasia. It is a benign, self-limiting, reactive inflammatory disorder of the salivary gland. It's clinically and histologically it resembles tumor, adenoid cystic carcinoma. The etiology is unknown. The clinical presentation is most commonly has painful and rapidly swelling of the hard pellets, ulceration from the center, and erythema in the periphery. The associated pain, it's sharp pain and has numbness or anesthesia. This is the early and the first sign and symptom of the lesion. And the lesion happened in the palate, and it happened in other places like the retromolar trigon and the buccal mucosa and tonsillus, the tongue, the nasal cavity, and the trachea and the maxillary sinus. In this picture we see the early lesion of the necrotizing cyalometaplasia, and here the late stage of the lesion. In this picture we see the retromolar trigon. Number of potential precipitating factor that has been suggested, like traumatic injury, dental injection, and ill-fitting denture, smoking, adjacent tumor, and previous surgery. The treatment is self-limiting condition, typically resolved in 3 to 12 weeks. Cheilitis granulitis, it's a chronic inflammatory disorder that affecting the minor salivary gland. It's thick saliva. It is secreted from the dilated duct opening. They are characterized by superficial ulceration, painless swelling, and the exudate appear at the ductal opening. The etiology is undetermined. It has been suggested it's autosomal demand hereditary disease, and the external factor it's UV light. The treatment it's elimination of the and using lip balm and sun cream for these people who more exposure to the sun. Allergic sialodentitis, the enlargement of the salivary gland, has been associated with exposure to various pharmacological agents and allergen like heavy metal and iodine compound. And thank you.